Hi everyone, this is Dr. Bharath, and in this section I'll be discussing the recall of FMG June 2021, and I will be discussing the pharmacology questions. Now, the exams are over and the results are already come, but why this video? Because this video will help you to recover whatever the questions that have come, and this will help you in the future exams, not only for the future FMG December 2021, and also for it's a clue for INACET as well as the NEET PG 2021. So with that information, let us start with the recall based questions, particularly the pharmacology questions. Now, let me start with the first question. A patient had pain and redness in grade 2. So obviously a pain and redness in the grade 2 and his uric acid levels were high. So it points towards the direct question. It's an acute gout. The doctor gave analgesics for pain and gave a drug for prophylaxis. So you know that there are two gouts, acute and chronic gout. Acute gout we use NSAID, colchicine and steroid. And for prophylaxis we use the drugs which either inhibit some enzymes, or we use uricosuric drugs, or we use a recombinant enzyme. So the drug acts by inhibiting uric acid synthesis. The drug may inhibit following enzyme. So what is the drug used in gout which inhibit uric acid synthesis? You know that there is an enzyme called xanthine oxidase, and that is inhibited by one is allopurinol and one more is febuxostat. Now if I read this question, uric acid oxidase is not inhibited. Now uric acid oxidase is an enzyme which will convert uric acid into allantoin, and the allantoin is water soluble. Now humans don't have this uric acid oxidase, so we have two enzyme preparation, that is pegloticase and rasparicase. So these are trending questions. Now xanthine oxidase is a rate limiting step, particularly when there is metabolism of purine to xanthine and xanthine to uric acid. There is an enzyme called xanthine oxidase. If that is inhibited, the uric acid synthesis is decreased. Now what is the drug which inhibit that? And that is none other than allopurinol, and one more is febuxostat. Carbonic anhydrase, it is inhibited by acetazolamide, and glucosidase is an enzyme used to treat methotrexate toxicity. So the answer for this question is xanthine oxidase. Now, if you look back at our classes which we dealt in eGurukul as well as DBMCI, this is the notes, and in the notes also we have highlighted the same concept that xanthine oxidase inhibition will decrease uric acid synthesis, and the drug which decrease that uric acid synthesis are allopurinol and one more is febuxostat. And we have also mentioned what are used for acute gout and what are used for chronic gout, what are uricosuric drugs and what are the enzymes. Those are the points which we have covered in the notes also. Now moving on to the second question. A drug used in depression acts by inhibiting both serotonin and noradrenaline reuptake. The drug is. Now the options are escitalopram. Escitalopram will inhibit only serotonin uptake, is SSRI. Fluoxetine is the longest acting SSRI, that is also SSRI. Bupropion belongs to atypical antidepressant, it is called NDRI. It is used for smoking cessation as well as weight loss. Venlafaxine is called SNRI, which inhibit the reuptake of serotonin as well as noradrenaline. So the right answer is D, venlafaxine. So same thing was discussed in the eGurukul and same thing was there in the notes. SNRIs we have mentioned venlafaxine, desvenlafaxine, milnacipran, duloxetine, which is there in the eGurukul notes. Now moving on to the next question. Which of the following is antidote for acute iron poisoning? I repeatedly tell in the classes that antidote, at least one question will be coming. Now the antidote for acute iron poisoning is desferrioxamine. So the drug which is used for acute iron poisoning is desferrioxamine. It's an iron chelator. Now this was discussed. What is iron poisoning? Patient either take it oral. Usually the childrens are prone for that. So the treatment is gastric lavage, and by making that the pH of the stomach alkaline and giving egg yolk decreases the absorption of iron, and the antidote is desferrioxamine, either given IV or IM. It's a chelating agent which will remove the iron from getting absorbed. Now, remember, the iron is more absorbed in duodenum, folic acid in jejunum, and B12 more in the ileum. So this is also one of the questions that was asked in FMG, and that is covered in the notes. So the answer is desferoxamine, which is called the antidote for acute iron poisoning. Now moving on to the next question. Which drug used in diabetes type 2 doesn't require dose reduction in renal failure? Now this is a very repeated question, particularly in All India Institute of Medical Sciences, and that's why I tell the FMG candidates at least to concentrate on few questions from All India Institute of Medical Sciences. Now it is called INSCT, and also from the NEET PG questions, because they may repeat. Now this is the third time this question has come. Vildagliptin, sitagliptin, linagliptin, saxagliptin, all these are DPP4 inhibitors, and you know that they all end with gliptins, and all are oral drugs. In that linagliptin, remember, linagliptin is mainly for liver, L for liver, so it is eliminated in bile and it undergoes enterohepatic recycling. So even in renal failure, you can give it with full dose without dose reduction. So the answer is linagliptin. Now this was discussed in the class in the notes, DP4 inhibitors. I told you the gliptins here, and particularly linagliptin, I told you bile elimination and undergoes enterohepatic recycling. So please note down this point. Dose reduction is not necessary in renal failure. So the answer is linagliptin, guys. Now moving on to the next question. Which of the following is not a bronchodilator? Which is a topic from bronchial asthma. Tiotropium, yes, it's a M3 antagonist, that is anticholinergic, which is a bronchodilator. Salbutamol is a beta 2 agonist, which is also a bronchodilator. Hydrocortisone is a steroid. Now this steroid increases the beta 2 responsiveness, but it is mainly an anti-allergic and anti-inflammatory drug. It is not going to do any bronchodilation. Now aminophylline, you know that theophylline, aminophylline, deriphyllin, these are called methyl xanthines, which act by inhibiting phosphodiesterase enzyme. So the answer is, which is not a bronchodilator, is hydrocortisone. And the future exam, they will also ask you whether magnesium sulfate is a bronchodilator or not. Yes, it is a bronchodilator used in acute severe asthma or acute attack of asthma. Same concept. This is the diagram. You can see the bronchus has been represented here, and the beta 2 agonist will increase cyclic AMP, that will cause bronchodilation. Now cyclic AMP is broken down into 5-AMP, and if you inhibit that by methyl xanthines, they also cause bronchodilation. But the M3 receptor cause bronchoconstriction, so I have to block them. So we have M3 antagonists which are used for asthma and COPD. The major use of anticholinergics are mainly in COPD compared to asthma. Now moving on to one more question. Dopamine. So dopamine at very low doses causes vasoconstriction, increased force of contraction, increased renal blood flow, and increase in angiotensin 2 levels. Now dopamine, you can use it in different levels, 1 to 2 microgram per kg per minute. This is the low dose, and 2 to 10 and more than 10. Now if you use it at these levels, 1 to 2, it will act on D1, and D1, you know that they are present in renal blood vessels, so which will cause vasodilation and they increase renal blood flow. 2 to 10, it acts on beta 1 and it increases the force of contraction and it increases the heart rate and conduction. Now more than 10, it will act on alpha 1 and cause vasoconstriction. Now they have asked very low dose, what happens? Very low dose, obviously vasoconstriction will not occur, which will occur at high dose, that is more than 10 microgram per kg per minute. Increased force of contraction at medium dose, so this is ruled out. Increased blood flow, that is the right answer. What about increases angiotensin 2 levels? It has nothing to do with this. So the answer is C, increases renal blood flow. Now this was the same thing what was discussed in the classes. Dopamine levels are mentioned here, 1 to 2, 2 to 10. Renal vasodilation increases urine output, and force of contraction, conduction because of beta 1 action, and more than 10, it acts on alpha 1 and cause vasoconstriction, right? So that vasoconstriction can be utilized for treating hypotension. Now moving on to the next question, it is the drug used used to close patent ductus arteriosus is misoprostol, anakinra, indomethacin, and alprostadil. Now remember, the misoprostol is a prostaglandin, particularly it is PGE1 analog. Now this misoprostol is used for, one is postpartum hemorrhage, right? It is used for medical termination of pregnancy, that is abortion, and it is also used in peptic ulcer disease. So that is misoprostol. Anakinra is interleukin 1 antagonist, and that is used in rheumatoid arthritis. It is used in rheumatoid arthritis. Indomethacin is an NSAID, and it can also be used in rheumatoid arthritis, osteoarthritis, gout. But the additional use of indomethacin is it is also used to close patent ductus arteriosus. Apart from indomethacin, what are the other NSAIDs which can be used is ibuprofen, and one more is aspirin. These are the things, but the drug of choice is indomethacin. Alprostadil, remember, it is also a PGE1, and that is used to maintain patent ductus arteriosus. Suppose you want to maintain patent ductus arteriosus, then we use alprostadil, and that is also used for erectile dysfunction. So it is also utilized for erectile dysfunction. So the answer is indomethacin. So please read the questions carefully. If they ask you to open, it is alprostadil, but here they have asked to close, then the answer will be NSAID, that is indomethacin. And prostaglandins will maintain that patent ductus arteriosus, NSAID will close it. So this is what we discussed about indomethacin. Indomethacin, in the notes we told that it decreases interleukin 1, it will decrease neutrophil chemotaxis, and decreases T and B cell proliferation. And it is the analgesic of choice in OA, rheumatoid arthritis, and acute gout. Now, one important issue is it causes severe frontal headache in few individuals. Can we use it for headache? Yes, it can be used. Only few individuals will experience that frontal headache. Now, it is contraindicated in epilepsy and psychosis. And remember, it is used for closing of patent ductus arteriosus. Now, moving on to the next question, drug used for diagnosis of myasthenia gravis. So many times the question of myasthenia gravis is repeating. Edrophonium is the one which is used for diagnosing myasthenia gravis. The reason why it is used is it is very short acting. So the test what we perform to diagnose myasthenia gravis is called Tensilon test. It is called the Tensilon test. Why the name Tensilon? Because edrophonium was also called as Tensilon. Now what about rivastigmine? Rivastigmine is an anticholinesterase which is reversible, used in the treatment of Alzheimer's disease. That is for Alzheimer's disease. Physostigmine is one more anticholinesterase. It crosses blood-brain barrier and it is used in the treatment of glaucoma, and it is a drug which can be used for atropine poisoning. Since it causes blood-brain barrier, atropine also crosses blood-brain barrier, we can use it there. Okay, so let me continue here. Now, this neostigmine is used in myasthenia gravis, and it also used to reverse the usage of D-tuberculin or to reverse the skeletal muscle relaxants, which are called non-competitive neuromuscular blockers. If they are used during surgery, then to reverse that, to reverse neuromuscular blockade. And neostigmine is also used in cobra bite, right? Now, what is that edrophonium test? Now, edrophonium test is a test used to diagnose myasthenia gravis. So what do we do here? We give 2 mg of the drug IV and see if there is improvement of muscle weakness. So usually myasthenia gravis will have ptosis, and we'll see whether the ptosis will improve. If it doesn't improve within 45 to 60 seconds, we give another 8 mg and see if there is any improvement. If it is more improvement, that implies that acetylcholine has increased and the patient is able to open eyelids comfortably. Now, many a times there is one more test called provocative test. That means we use D-tuberculin, and when you use that, obviously the muscles will get relaxed and patient will have exaggerated symptoms. That is not practiced nowadays. So edrophonium test is also called as Tensilon test. It is used for the diagnosis of myasthenia gravis. This is also a repeated question from NEET exam. Now, moving on to the next question, which of the following diuretic is preferred in a patient with road traffic accident with head injury and raised intracranial pressure? Now, any raised intracranial pressure, it will lead to a condition called cerebral edema. Now, when you treat cerebral edema, the main drug what we use is called mannitol, which is an osmotic diuretic. Now, you can use furosemide, but it's not the main drug. It's an adjuvant drug which is given. Now, furosemide is a drug which is a diuretic of choice in an edema called pulmonary edema. So, this was also asked. Now, can you tell me, guys, which is the diuretic which should not be used in pulmonary edema? The diuretic which should not be used in pulmonary edema is mannitol. What is the reason for that? The reason is mannitol increases ECF volume, and that will put the back pressure on the heart. The heart fails further, the pulmonary edema worsens. So that is one more question they ask you again and again about mannitol. What about spironolactone? Spironolactone is used in one important point is Cohen syndrome, which is because of hyperaldosteronism. Now, spironolactone is also used to treat hypokalemia because of diuretics. It is also used in chronic CHF. Now, among all the diuretic, spironolactone is the only one which decreases mortality. Now, another specialty with the mechanism of action is all the diuretic act from luminal side of nephron, but this acts from interstitial side of nephron. That is the specialty of this. Now, ostazolamide, it's a carbonic anhydrase inhibitor, and this is also asked. It is one of the drug used for acute mountain sickness. So it is used for acute mountain sickness. Now, moving on to this is what we discussed in our classes. Uses of osmotic diuretics, that is cerebral edema, where there is increase in intracranial pressure, acute congestive glaucoma, where there is increase in intraocular pressure, poisoning to wash out that poisons, that is not practiced nowadays, cisplatin toxicity, and impending renal failure. The usage of mannitol in these two conditions, poisoning and cisplatin toxicity, is not that much these days, but historically it was used earlier for these conditions. Now, this is a stock question. There is no mistake to be done with this. Now, drug of choice for anaphylactic shock, they may ask like anaphylactic shock, or the question would have come like this. A patient was given penicillin and immediately he had swelling of lips, rashes everywhere, and what is the treatment of choice? So that is nothing but anaphylaxis and anaphylactic shock. The drug of choice is adrenaline. Remember, the dose is 1 in 1000 and the route preferred is IM, and you can also give subcutaneous, but the preferred is IM. And the muscle what we particularly prefer is vastus lateralis, because the studies have shown maximum absorption with that, and the dose in an adult is 0.5 milligram, or in the syringe it is 0.5 ml that can be given. So that is the drug of choice. Why this is the drug of choice? In anaphylaxis, there is histamine action, and the histamine action will be bronchoconstriction, vasodilation. That will be reversed by adrenaline, because adrenaline is physiological antagonist. That was the question asked in previous FMGE exam. Now, isoprenaline is mainly acts on beta 1 and beta 2. This is particularly used whenever the patient has bradycardia or the patient is having AV block. So there isoprenaline is used. Now, atropine is used mainly in the treatment of OP poisoning, and in cardiac it is used in bradycardia and AV block. Noradrenaline acts on alpha 1, alpha 2, beta 1, but it has no beta 2 action. Now, where do you use adrenaline then? It is used in severe hypertension. Only in severe hypertension it can be used in septic shock. And that is about the drug noradrenaline. So the drug of choice for anaphylactic shock is adrenaline. Many students ask me this question, sir, why not noradrenaline is the drug of choice for anaphylactic shock? Remember, the adrenaline is physiological antagonist. That is point number 1. Second point, noradrenaline has no beta 2 action. That means we cannot dilate the bronchus. So that's the reason adrenaline is the drug of choice for anaphylactic shock. Now, this was discussed in the class also. So adrenaline, I told you, it has non-specific action. It acts on alpha 1, alpha 2, beta 1, beta 2, and beta 3. It is the drug of choice for anaphylactic shock. Preferred is intramuscular more than subcutaneous. Preferred muscle, preferred dose. And based on weight also, we have given the dosages here. Less than 10, 10 to 25, 25 to 50, more than 50. So adult is 0.5 milligram per kg. So this is how we had discussed this. And for your this thing, you have to remember only 0.5 to 0.5 milligram, that much is fine. So no need of remembering as the kg. So the dose is 0.3 or 0.5 milligram. In mls it is 0.3 to 0.5 ml. That is the important thing. Now moving on to this image based question. Identify the true statement from the log dose response curve. Now this, whenever the graph is given, you have to analyze what is there in x-axis, what is there in the y-axis. X-axis, if I expand, you can find out the log concentration, that is drug concentration in this, and the response in y-axis. Now remember, whenever there is drug concentration or dose, it represents the potency of the drug. Potency, and the response will tell us the efficacy. So simple thing is, if you move in y-axis more and more, the efficacy increases, but potency, if you move from left to right, the potency decreases, because the log dose or the log concentration is inversely proportional to potency. So with that background in the mind, let us see the true statement. Drug A is more efficacious. Now efficacy is given here, the maximum response. Yes, drug A is more efficacious, even the drug B is more efficacious. So this looks like true statement. But let me not stop here and read other options. Drug A and B are equally potent. Now potency means relative to dose. Drug A and B, they are not equally potent, but they are equally efficacious. Now if I want to compare the potency, you see I take a ED50, and according to ED50, if it is closer to the left hand side, that means it is more potent, and if you use the drug more quantity, it is less potent. That is what I told you, they are inversely proportional. So the drug A is more potent than drug B. Now drug C is most potent. No, drug C is the least potent, because you see it has shifted towards that side. What about drug D? Drug D is, this is also false statement. Drug C is the least potent one, that is also false statement. What about drug D? Is less potent and less efficacious than drug A. So is it so? Drug D is more potent than drug A, and it is less efficacious than drug A. So here the statement is false. So drug A is more potent than A. Suppose I write their efficacy. A and B are equally efficacious, and they are more efficacious than C and D. C and D are equally efficacious because they are achieving the same levels. So efficacy, when I am taking, I don't consider the dose at all. Now coming to the effective dose 50, the most potent is, if I write potency, D more than A, more than B, more than C. This is what we mean by potency. So what is important in clinical practice is the efficacy. So this was the thing what we discussed in the class illustration. So response and efficacy log dose. So you can see A, B, C, and efficacy wise, I told you A and B are equally efficacious and C is less. So because in y-axis it is lesser. Potency wise, A is more potent than B than C. So this is the potency graph which we discussed. Now moving on to the next question. Drug of choice for treating ventricular tachycardia due to digoxin toxicity. You know that digoxin can cause all type of arrhythmia except two, that is Mobitz type 2B and the atrial flutter. Now lignocaine is the drug of choice for digoxin-induced ventricular tachycardia. Can we use quinidine, verapamil, amiodarone? No, because these inhibit a protein called pre-glycoprotein and thereby increases digoxin further. So the digoxin toxicity is worsened by them. That's why they are not used. So this was discussed when we discussed the arrhythmia treatment, particularly the digoxin-induced arrhythmia. For tachyarrhythmias, if it is because of chronic digoxin use, just give potassium infusion, because potassium will inhibit the binding of digoxin to that. But if it is because of acute ingestion of digoxin, there will be hyperkalemia already. So there you should not use potassium because dangerous hyperkalemia will occur. So better to give a beta blocker. Ventricular arrhythmia, whether it is tachycardia or fibrillation, give lignocaine. Don't use amiodarone because it increases digoxin level. SVT beta blockers are used. AV blocker, you can use cardiac pacing. That is the best one, or you can go for atropine or isoprelol. Moving on to the next question. A patient was given halothane for general anesthesia. He developed rigidity and hyperthermia. So muscle rigidity and hyperthermia with a general anesthesia like halothane, this points towards malignant hyperthermia. So certain anesthetics like fluorinated anesthetic like halothane, some of the muscle relaxant like succinylcholine, they can cause this malignant hyperthermia. These symptoms are most likely due to which ion? Sodium, potassium, calcium, or chloride. It is mainly because of calcium. Now, this was discussed when I discussed dantrolene sodium. Now, dantrolene sodium is considered the drug of choice for neural malignant syndrome and malignant hyperthermia. What is the problem here? The calcium channels are hyperactive. Because of that, the patient will have muscle contraction. They will have more muscle contraction. So, I need to block the ryanodine receptor, and that is blocked by dantrolene. So, the ion that is going to cause this malignant hyperthermia is calcium. So the answer for this question is calcium. That is the answer. Now moving on to the next question. A man traveled to Assam. After coming back, he developed fever, chills and rigors and altered sensorium. The peripheral smear demonstrated falciform. What is the treatment of choice? Chloroquine plus primaquine. That is the one which we use for Vivax because Vivax and Vowel, they are still sensitive for chloroquine. Sulfadoxine plus pyrimethamine, they are slow acting. They have to be added with artesunate. Then only we can use artesunate combination therapy for falciform malaria. Lumefantrine plus artemether, yes, this can be used, but this is approved in northeastern state. And sulfadoxine plus pyrimethamine is approved in rest of India along with artesunate. So this intravenous artesunate is used whenever there is complicated malaria or cerebral malaria, then the drug of choice will be IV artesunate. Now, please understand, northeastern state, why do we use lumefantrine plus artemether? Because in that state, sulfadoxine, pyrimethamine have acquired resistance. So that's why we use it. Now, this was a chart which we discussed in the class, treatment of malaria. Vivax and Vowel, we use chloroquine and primaquine for 14 days. Falciform malaria and malariae, we use artesunate combination therapy. Patient from northeastern state, we use artemether plus lumefantrine. Rest of India, we use sulfadoxine plus pyrimethamine plus artesunate. If it is a mixed infection, we use ACT plus primaquine into 14 days. So this is how we treat malaria. Okay, so let's move on to the next concept. A patient had a previous history of previous child with Down syndrome, currently on lithium therapy, presents for antenatal checkup. Which of the following condition is the fetus at the greater risk for? Now, lithium toxicity, particularly for pregnant women, it's a teratogenic drug, and this is being repeated a lot. So, will it call abstinence anomaly, Down syndrome, tetralogy of Fallot, or neural tube defect? Lithium causes serious defect, and that is the abstinence anomaly. That is the right answer. Now, neural tube defects are caused by mainly the carbamazepine as well as valproate. To prevent that, what we use as a supplement is a question asked. It is folate. Now, did we discuss this in the class? Yes, the ADR of lithium, we give a mnemonic fell hence, and in that abstinence anomaly was also discussed as a problem with lithium. So next one is, after eating an unknown plant, a child present to the emergency in comatose state, the pupils were dilated and skin was dry. Body temperature is raised and heart rate is high. These are signs and symptoms can occur with intake of which of the following substance? Now, datura, poppy seeds, mushroom, cannabis. Now, a simple pupil can tell you the poison. Suppose the pupil is mydriatic or meiotic. Now, remember, if it is mydriatic, two things possible. It may be anticholinergic or it may be sympathetic. Anticholinergic such as atropine, sympathetic such as the cocaine, or it may be amphetamine. Now, meiotic, two possibility. One is the OP poisoning, that is cholinergic, and one more is opioid. These are possible. Now, the patient is having pupil that is dilated and skin is dry and temperature is high. That means that points towards atropine because of atropine fever. And they have given not given atropine, but they have given datura, and datura is a source of atropine. It's a forensic pharmacology question. Poppy seeds, they are nothing but opioids, so they will cause meiosis. So the right answer is datura. So this was the point which was discussed in the class atropine poisoning. What are the features what we see in atropine poisoning? Pupil dilated, dry mouth, delirious, heart rate increase, confusion, blurring of visions, and 3 C's of atropine poisoning. What is the antidote? It is physostigmine. Now moving on to the next question, because we recollect the question from other sources. A farmer presented to the emergency with garlic odor, pinpoint pupil, excessive secretions. What is the antidote for this? Now, pinpoint people, I told you two things possible, either opioid or OP, and it's a farmer. Obviously, it will point towards the OP compound poisoning. So the antidote for that is atropine. That is the right answer. Flumazenil is an antidote for benzodiazepine poisoning. N-acetylcysteine. N-acetylcysteine is for paracetamol poisoning. Flumazenil for benzodiazepine poisoning. Oxymes. Oxymes are not an antidote, but they are used in OP poisoning. But they are asking you drug of choice, and the drug of choice is atropine. So the same thing was discussed in the class. OP poisoning. What are the features in OP poisoning, and what are the steps to be taken in OP poisoning? Managing airway, atropine, what are the signs of atropinization? Should we use a diazepam? Then what is enzyme reactivators? They are called oxymes, pledoxime, obidoxime. Those things are discussed in the class. Now moving on to this question, which of the following drug is long-acting phosphodiesterase 5 inhibitor? You know that phosphodiesterase inhibitors are used in two conditions. One is erectile dysfunction and one more is pulmonary hypertension. Now all are tadalafil, avanafil, sildenafil, vardenafil, all are phosphodiesterase inhibitors. So I always teach the student to write it as ASVT. You remember PSVT? Similarly, you remember it as ASVT. A is avanafil, sildenafil, vardenafil, tadalafil. The shortest acting is avanafil and the longest acting is tadalafil. So the answer is tadalafil, which acts more than 24 hours. Now you remember T also has tall. Tadalafil is tall, so it will be long. So long acting is tadalafil. So this was the thing what we discussed when we discussed management of erectile dysfunction. Sildenafil, tadalafil, vardenafil, avanafil. They are used, particularly sildana and tadala are used for pulmonary hypertension. In that, the longer acting is tadalafil. So elderly male developed symptoms of dementia and was diagnosed Alzheimer's disease. Which neurotransmitter is involved? Is it dopamine, acetylcholine, adrenaline, and serotonin? Dopamine level is decreased in Parkinson's disease. Acetylcholine levels play a major role in Alzheimer's disease. So this is the right answer. Adrenaline, nothing to do. Serotonin is playing a role in depression. So the answer is acetylcholine, and this was discussed during cholinergic drugs. So we discussed the drugs for Alzheimer's disease which increase acetylcholine, tachycardia. Then we discussed rivastigmine, galantamine. So those are the drugs which are used for Alzheimer's disease. Okay guys, that's it from the pharmacology recall based question. The purpose of this video is to get you the idea that what were the questions asked, and most of them were the repeated questions which are taught in the classes, and eGurukul particularly has covered most of the concept for you all, and this will also be useful if you are attempting next FMG exam or the NEET PG 2021 or INACT. So thank you all, thank you and take care.